Module 8, Integrated Delivery Room Cases and Local Protocol Reconciliation. This is Module 8 of Delivery Room Labor Failures, Integrated Delivery Room Cases and Local Protocol Reconciliation. The course ends where real obstetrics happens, not in a table, not in a single guideline sentence, but in a patient whose labor has a clock, a cervix, a uterus, a fetal tracing, a pelvis, a fetus, a local protocol, and a frightened family waiting for a decision. The skill we are building now is the ability to say the decision out loud. Not vaguely. Not as, she is not progressing. Not as, the tracing is not great. Not as, I think we should do a cesarean. A defensible delivery room formulation has anatomy. It says the phase of labor, membrane status, oxytocin exposure, contraction adequacy, fetal status, mechanical findings, modifiers, local protocol constraints, and the reason the next step is safe. The sentence sounds like this. This patient is in this phase with these membranes, this uterine activity, this fetal reserve, these mechanics, and this modifier. Therefore, the safest next step is this, because these criteria are met or not met. That sentence is not decoration. It is the clinical mind made audible. Let us rehearse it. First case, the long induction that feels endless.
A nulliparous patient is admitted for post-date induction with an unfavorable cervix. She receives cervical ripening overnight. In the morning, she is 4 centimeters, 70% effaced, -2 station. Membranes are intact. The fetal tracing is category 1. The team is tired. Someone says, she has been here forever. This is a failed induction. That sentence is wrong. The reason is not optimism. The reason is definition and biology. Failed induction is not diagnosed by the number of hours since admission. Ripening time is cervical tissue biology, collagen remodeling, softening, effacement, hydration, and readiness. The cervix may be becoming inducible even when it is not yet in active labor. The relevant failed induction clock is not the waiting room clock. It is the clock after an adequate induction trial. Rupture, oxytocin, reassuring maternal and fetal status, and enough time. ACOG-style teaching gives a minimum of 12 to 18 hours after rupture with oxytocin if the mother and fetus are reassuring. The conservative Spong and Gabbe frame asks for at least 24 hours of oxytocin with ruptured membranes if feasible. The Israeli position paper requires at least 12 hours of Pitocin plus artificial rupture as early as possible, with ruptured membrane duration preferably at least 24 hours, and excludes ripening time. So the decision sentence should be,
This is a prolonged latent induction, not failed induction. She has not had ruptured membranes with oxytocin for the required interval, and maternal and fetal status are reassuring. The safest next step is to continue the induction plan. Consider amniotomy when clinically appropriate, begin or continue oxytocin safely, and reassess by the correct clock. That is diagnostic patience. It is not passivity. It is refusing to convert cervical biology into a premature cesarean. Second case, the 6-centimeter gait. A patient is 6 centimeters, ruptured on oxytocin. 4 hours ago, she was 6 centimeters. Contractions are regular, but external monitoring is poor because of maternal habitus. The tracing is category 1. Someone says, she meets arrest, cesarean. Maybe, but not yet unless contraction adequacy has been addressed. Active phase arrest requires the correct phase, ruptured membranes, and absence of dilation after either 4 hours of adequate contractions or 6 hours of inadequate contractions with oxytocin. 6 centimeters is the gate into active phase arrest reasoning, but the gate is not the whole diagnosis. The uterus must be evaluated. If contraction adequacy is unclear,
The clinician must decide whether external assessment is sufficient or whether an IUPC would clarify the powers. The historical adequate benchmark is 200 MVU. We do not worship the number, but we respect the question it asks. Is the uterus doing enough work to make arrest meaningful? The decision sentence.
This patient is at the active phase threshold with ruptured membranes and no dilation for 4 hours, but contraction adequacy is not established. Because the tracing is reassuring and external contraction assessment is unreliable, the next step is to measure or better assess uterine activity, continue safe augmentation if inadequate, and diagnose arrest only when the contraction time criterion is truly met. If the IUPC shows adequate contractions for 4 hours with no change, the sentence changes. This is active phase arrest, 6 centimeters or more, ruptured membranes, no dilation after 4 hours of adequate contractions, reassuring tracing, and no correctable mechanical or fetal status reason to continue. Cesarean is now indicated. The difference between those two sentences is the difference between guesswork and diagnosis. Third case, protraction with tachysystole. A patient is 7 centimeters, ruptured, on oxytocin for protraction. The cervix has changed slowly, from 6 to 7 over several hours. The monitor now shows more than 5 contractions in 10 minutes averaged over 30 minutes, recurrent late decelerations, and moderate variability. A resident says, she is slow, increase oxytocin. This is the moment Module 5 was built for. The cervix is slow, but the uterus is already exceeding safe frequency. Tachysystole is more than 5 contractions in 10 minutes, averaged over 30 minutes. With recurrent late decelerations, the fetus is declaring that the contraction pattern is interrupting the oxygen pathway. Moderate variability is reassuring against current significant acidemia, but it is not permission to worsen the stress. The correct question is not how to make more contractions. The correct question is how to restore recovery time while preserving the possibility of vaginal birth. The decision sentence. This is active labor with protraction, not arrest, because there is still cervical change. However, oxytocin is now producing tachysystole with a Category 2 tracing. Because moderate variability suggests current reserve, but late decelerations indicate impaired uteroplacental oxygen transfer, the next step is to reduce or stop oxytocin, reposition, assess blood pressure and maternal status, treat reversible causes, and reassess the tracing before any further augmentation. If the tracing improves, you have restored physiology. If variability worsens, accelerations disappear, decelerations persist, or the tracing becomes Category 3, the decision changes towards expedited delivery. Fourth case, the second stage that is long but not static. A nulliparous patient with epidural has pushed for 3 hours and 20 minutes. The fetal tracing is Category 1. The head has descended from 0 to +2, and the position has rotated from OP toward OA. The mother is tired, but still participating. Someone says, 3 hours. Arrest. That is not how second-stage arrest should be diagnosed. ACOG defines prolonged second stage as more than 3 hours of pushing in nulliparous and more than 2 hours in multiparous, with individualized diagnosis. Israeli language separates prolonged second stage from arrest and uses no station change after at least 3 hours of pushing in nulliparous or 2 hours in multiparous as the arrest concept. Gabbe reminds us that protraction of descent and arrest are not identical. Here, the second stage is prolonged, but it is not static. Descent and rotation are occurring. The fetal tracing is reassuring. The question is not whether the clock has crossed a line. The question is whether continued pushing is still safe and likely to achieve vaginal birth. The decision sentence. This is a prolonged second stage in a nullipara with epidural, but not established arrest because descent and rotation continue and fetal status is reassuring.
The next step is individualized continuation with senior reassessment of station, position, caput, maternal exhaustion, and operative delivery candidacy, with clear limits for what would change the plan.
The limits matter. If station stops changing, rotation stalls, caput worsens, maternal exhaustion becomes unsafe, or fetal status deteriorates, the decision must be revisited. Fifth case: operative vaginal delivery versus second-stage cesarean. A multiparous patient is complete, pushing, and now has recurrent deep variable decelerations. Between decelerations, there is moderate variability. The head is outlet, OA, membranes ruptured, bladder empty, pelvis adequate, estimated fetal weight reasonable, pediatrician present, senior operator in the room, and cesarean backup ready. This is an appropriate context to consider operative vaginal delivery. The reason is not that vacuum is less invasive. The reason is that all the safety architecture is present. Full dilation, ruptured membranes, low or outlet bony station, known position, adequate pelvis, estimated fetal weight assessed, analgesia, consent, empty bladder, neonatal team, skilled operator, and a stopping rule. The tracing creates a reason to shorten the second stage, but the anatomy creates permission. The decision sentence. This is a second-stage patient with suspected fetal compromise, outlet OA position, known station, adequate prerequisites, and an experienced operator present. Operative vaginal delivery is a reasonable alternative to second-stage cesarean, provided the patient consents, the team is ready for immediate cesarean if the attempt fails, and descent occurs with traction. Now alter one fact. The head is +1 with significant caput, position uncertain between OP and OT, estimated fetal weight above 4,000 grams, and the operator is junior. The same tracing is present. Now the sentence changes. This patient needs delivery, but operative vaginal candidacy is uncertain because bony station, position, fetal size, and operator experience raise failure risk. The next step is senior bedside assessment. Ultrasound if position or station remains uncertain, double setup if a carefully selected attempt is considered, or cesarean if the mechanics are not favorable. No descent with traction is not an invitation to pull harder. It is diagnostic information. Local vacuum rules require reassessment after lack of progress, stopping after 3 pop-offs, limiting traction duration, and proceeding immediately to cesarean after failed instrumental delivery. The instrument must never become a prolonged experiment. Sixth case, first TOLAC. A patient with 1 previous low transverse cesarean and no prior vaginal birth is in labor. She is 6 centimeters, ruptured, on local low-dose Pitocin. The tracing is category 1. She has been unchanged for 2 hours. A resident says she is multiparous, so she should move faster. Maybe this is a rest. This is exactly the wrong shortcut. The Israeli position paper says progress criteria are the same as regular birth, but if there was no prior vaginal birth, expected progress resembles nulliparous labor. The local protocol allows Pitocin at quarter dose, up to 20 milliunits per minute, requires senior involvement for induction, avoids prostaglandins, and limits first TOLAC second stage to 2 hours, extendable by 1 hour with epidural. At 6 centimeters with 2 hours unchanged, she does not meet active phase arrest criteria, but the scar modifies the monitoring and escalation strategy. The decision sentence. This is a first TOLAC without prior vaginal birth, so progress should be interpreted closer to nulliparous expectations. She is at 6 centimeters with ruptured membranes and reassuring tracing, but only 2 hours unchanged, so active phase arrest is not met. Continue careful scar-aware management, maintain continuous fetal and uterine monitoring, use only local low-dose Pitocin within protocol, and reassess for rupture signs or arrest criteria. Now, change the tracing.
sudden prolonged bradycardia, severe abdominal pain, vaginal bleeding, and loss of station. The decision sentence becomes, this is no longer labor dystocia. In a TOLAC, fetal heart rate abnormality with pain, bleeding, and loss of station is suspicious for uterine rupture. Stop oxytocin if running, call the team, and proceed to emergency delivery. The power of the course is knowing when the labor failure framework no longer applies because a surgical emergency has replaced it. 7th case, suspected macrosomia with diabetes.
A patient with diabetes is estimated at 4,100 grams. The cervix is complete, the head is +1, OP, with significant caput. The tracing is category 1, the mother is exhausted. Someone says, try vacuum because cesarean in 2nd stage is morbid. The statement contains one truth and one danger. 2nd stage cesarean is morbid, but that does not make vacuum safe. Macrosomia is uncertain, but it modifies the mechanics. Diabetes modifies shoulder dystocia risk because fetal growth may be disproportionate. The local macrosomia protocol recommends cesarean above 4,000 grams in diabetic women, while the Israeli position paper uses 4,250 grams and ACOG uses 4,500 grams. Those differences do not mean the number is meaningless. They mean the resident must explicitly reconcile local practice, source disagreement, EFW uncertainty, and the actual mechanics. Here, +1 station, OP, caput, diabetes, and suspected large fetus all increase the risk of failed operative vaginal delivery or shoulder dystocia. The fact that the tracing is reassuring gives time to reason. The decision sentence. This is a diabetic patient with suspected macrosomia, uncertain but concerning EFW, +1 station, OP position, significant caput, and maternal exhaustion. Although 2nd stage cesarean carries morbidity, operative vaginal delivery is not favored unless senior assessment establishes high likelihood of success. Local macrosomia thresholds and shoulder dystocia risk must be part of counseling and route planning. 8th case, infection and maternal disease. A patient has ruptured membranes for many hours during induction. Maternal fever, uterine tenderness, fetal tachycardia, and slow cervical change at 5 centimeters. Another patient has PET with severe features at 35 weeks, on magnesium, with rising blood pressures and a cervix still latent. In both cases, someone asks whether the full failed induction clock has been completed. That is the wrong first question. In chorioamnionitis, delivery plus antibiotics is the central treatment. In PET with severe features, delivery from 34 weeks is the local timing frame, with earlier delivery if maternal or fetal condition demands it. The induction clock still matters if mother and fetus are stable enough for labor, but infection and severe maternal disease change tolerance for time. The decision sentence for infection. This is a ruptured membrane induction with clinical concern for chorioamnionitis. The issue is no longer only failed induction criteria. Infection changes the safety of continuing. Begin antibiotics, notify pediatrics, assess maternal and fetal status, and choose the route that achieves delivery safely without pretending that the standard latent induction clock is the only variable. The decision sentence for PET. This is PET with severe features at a gestational age where delivery is indicated, on magnesium, with worsening maternal status. The route depends on maternal stability, fetal status, cervical favorability, and expected time to vaginal birth. But the induction plan is subordinate to maternal safety. These cases are where residents must understand the difference between definition and tolerance. The definition of arrest may be unchanged. The tolerance for waiting may be profoundly changed. Now, let us gather the course into one final framework. When you are asked whether a labor has failed, do not answer with a single number. Build the answer in layers. Layer 1, phase. Is this latent labor, active labor, or 2nd stage?
Before 6 centimeters, do not apply active phase arrest. In latent induction, ask whether ripening, rupture, oxytocin, reassurance, and time have created a fair induction trial. Layer 2, progress. Is there dilation, effacement, descent, or rotation? Protraction is not arrest. Slow change is not no change. Station without position is incomplete. Layer 3, powers. Are contractions adequate, excessive, or unknown? If inadequate, augmentation may be appropriate. If tachysystolic, more oxytocin is physiologically wrong. If adequacy is uncertain and the decision depends on it, consider better assessment. Layer 4, fetal reserve.
Category 1 permits routine management. Category 2 requires interpretation, correction, and reassessment. Moderate variability and accelerations are powerful reassurance against current significant acidemia. Category 3 that persists despite corrective measures requires delivery as expeditiously as feasible. Layer 5, mechanics. What are station, position, caput, molding, estimated fetal weight, pelvic adequacy, and rotation? Before operative vaginal delivery, every prerequisite must be real, and the stopping rule must be explicit. Layer 6, modifiers. TOLAC changes scar risk and oxytocin discipline. Macrosomia changes mechanical probability and shoulder dystocia readiness. Diabetes changes fetal size distribution and neonatal planning. PROM and PPROM change infection exposure and examination discipline. PET changes maternal timing and tolerance. PPH and VTE risk change root preparation and postpartum planning. Layer 7, local protocol. This is where source reconciliation becomes mature. ACOG may give a conceptual anchor. Gabbe may deepen the physiology. Spong may give a cesarean prevention frame. Israeli position papers may set national practice. Local protocols may define how your department expects Pitocin, TOLAC, vacuum, PPROM, PET, PPH, and intrauterine resuscitation to be executed. The resident must know which layer is being used. The final decision sentence is the product of all 7 layers. Do not say she failed induction. Say, she is still latent after ripening, but has not yet had ruptured membranes plus oxytocin for the minimum diagnostic interval, and maternal and fetal status are reassuring. Failed induction is not yet met. Do not say, she arrested. Say, she is 6 centimeters with ruptured membranes and no change after 4 hours of adequate contractions. Active phase arrest criteria are met. Do not say, the tracing is bad. Say, this is category 2 with recurrent late decelerations, but moderate variability during oxytocin tachysystole. Stop or reduce oxytocin, resuscitate, and reassess. Do not say, try vacuum. Say, the head is outlet OA, prerequisites are met, the operator is skilled, the pediatrician is present, cesarean backup is ready, and descent must occur with traction. Operative vaginal delivery is reasonable. Do not say, she is special. Say, she is a first TOLAC without prior vaginal birth, so the scar modifies augmentation and second-stage tolerance, while progress expectations resemble nulliparity. This is the level of speech that creates safe care. It is also how you teach younger residents. The sentence disciplines the mind. It exposes missing criteria. It prevents false certainty. It shows the team what would change the plan. The course ends with this image: a resident at the bedside, not reciting a table, but reading labor as physiology in motion. Cervix, uterus, fetus, pelvis, placenta, scar, infection, blood pressure, hemorrhage risk, route, and protocol, all present at once. That is why the subject is beautiful. Labor failure is not a crude label attached to slow progress.
It is a diagnosis earned only after the clinician has respected normal labor, cervical biology, uterine power, fetal oxygenation, second-stage mechanics, operative skill, and the modifiers that make each patient particular. The final synthesis is this: a cesarean for labor failure should never be the result of impatience, imprecision, or fatigue. Continued labor should never be the result of denial. Operative vaginal delivery should never be the result of desperation. Oxytocin should never be escalated against fetal physiology. Local protocols should never be treated as bureaucratic decoration. The best decision is the one that can be spoken clearly. Criteria, mechanism, modifier, protocol, next step, and trigger for change. That is the clinician this course is trying to build.